I'm Annie Burwell. I'm with Williamson County Mobile Outreach Team. We provide emergency behavioral health care for Williamson County. We're a division of Williamson County EMS.
Yeah, I'm Eric Higginbotham. I'm the medical director at Dell Children's Medical Center Emergency Department.
I'm Sivasankar. I am one of the pediatric emergency room physicians at St. David Children's Hospital.
And I think today what we're going to do is talk about the best way to assist children who are having a psychiatric emergency and what we can all do to take better care of them. Can you guys both talk a little bit about what you're seeing lately in terms of trends or an uptick in certain populations or types of situations that are coming your way?
Sure. So I think it was a New York Times article recently that talked about the mental health crisis in kids as a result of the pandemic. We're sort of living through that right now. And so any kid that has had an underlying psychiatric disorder like depression, I think that the COVID pandemic has exacerbated that. They've, weren't attending school for a while. Even at school now there's increased stress. Mm-hmm. And they're reaching these points of psychiatric emergency. And so we're seeing numbers I haven't seen in terms of presentations during a shift of someone who's acutely suicidal or are coming in with psychosis symptoms or manic symptoms. It's quite a burden right now.
Mm-hmm. Any particular age group that you're seeing more of that's surprising to you?
Younger than they used to be. So elementary age kids are coming in with acute suicidality.
Mm-hmm.
I would have to agree with Dr. Higginbotham here. Just the other day, I think we had someone that was 8 years old with symptoms that we typically don't see in that age range. And this isolation that has really been present during this pandemic has really ramped up a lot of suicidality and feelings of isolation and increased things like online bullying that I'm seeing a lot of that are leading these kids to have these types of thoughts and go ahead with some of these actions that are very dangerous to them.
We're seeing more young adults overdosing on pressed pills, opioids, and we're super concerned about that. Are you seeing a similar pattern?
Definitely, especially the young adults, maybe late teens, early 20-year-olds. I have seen multiple heroin overdoses over the past few months compared to what I usually see. And I would say that for me personally, I hadn't seen that many before, and I definitely have seen a spike in that. And I'm not entirely sure what the big cause of seeing such a huge spike in that is, and it could definitely be some underlying anxiety, depression. This whole pandemic situation has really taken a toll on the mental health of pretty much everybody. And it's just how we manage that stress and kind of deal with it that shows us who we are.
Mm-hmm.
Yeah, the self-medication there from that what we were just talking about before this. So I don't think this was a sudden change in direction, like you said when you brought it up. It's a direct response, I think, to how people are dealing with the stress of the pandemic, be it financial, family, and so we're seeing a lot of Xanax overdoses in the population I'm seeing. Mm-hmm. Yeah, I've had colleagues that talk about how in their communities they're seeing fentanyl pressed into the form of some of these of Xanax tablets. Mm-hmm. We, as far as I know, we've maybe had one or two of those, but not a large number yet. I don't know if that number is going to go up. Mm-hmm. So yeah, we're seeing, that tends to be the call from the school. You mentioned school being called where someone is acting altered or someone is voicing suicidal ideation. When they get to us, we find out that they took 4 or 5 bars of Xanax and are just showing the signs of that benzo ingestion.
Can you tell us a little bit about what happens once we bring a child or an adolescent your way? What happens in the emergency department when it's primarily a psychiatric issue?
Yeah, I think the first thing that we do is our job is to perform a medical clearance on the patient. And sometimes that involves getting some blood work and some lab work, really talking to the caregivers or family members that are with a child, talking with the child themselves to understand a little bit about what caused this issue and what's going on. And once we've gotten through this medical clearance portion, we then liaise with our social work team, which are just phenomenal people, and they really help us out. And they too talk with the patient, talk with the family, and then together as a team, we come up with a decision that is going to be in the best interest for the patient, for the child, and really take their safety into priority and understanding what the parents want as well, and try to come up with the best plan for them. And sometimes that is a more intensive outpatient therapy regimen, sometimes that is inpatient hospitalization, and sometimes that is even getting someone like psychiatry or telepsychiatry involved in helping us make that decision.
We're fortunate enough to have sometimes multiple social workers on shift depending on what the volume is. And so that social worker, they tend to be doing everything in parallel, just like Sean was talking about. But, we're doing the medical clearance part. We're talking with the patient. We're talking with the family. We're really trying to get at what the underlying crisis was that precipitated in them coming. And then we try to come up with sort of a placement that if we feel they can go home safely, we do that. By the time they end up in the emergency room, though, I will tell you that whatever crisis occurred really precipitated some behavior that got them there. And so the majority of what we see are kids that then need inpatient placement. And then so we have a set of labs that most psychiatric hospitals want. We get those. We tend to do an ECG on them. And that's because sometimes they'll be starting antipsychotics, and that can change some of the intervals on the ECG. And then in all the female patients, we're making sure that the crisis that precipitated the suicidality is in pregnancy. And we see that happen sometimes.
So one reason that we get called to a home or to a school seems to be a recent change in medication, or perhaps the medication isn't working, or at least that's what we're being told. We often hear from parents that it's really frustrating because the doctor or the psychiatrist is kind of constantly fiddling with the medications, and we know that growth can be a factor, and hormonal changes can be a factor, and just kind of what's going on in the environment can be a factor. Your sort of thoughts and opinions about what challenges that brings.
So we're fortunate in that we have access to both telepsychiatry and then a psychiatric consult service. So that's a resource that not a lot of other hospitals have access to. And I know to be fortunate for that, because it gets to the point that you're asking about. We can ask them to come see the kid, and perhaps they do come up with an idea of adjusting some medications. The one positive of this backlog of getting into a psychiatric facility is sometimes we can make that adjustment in the ED, and because the kid's not going anywhere for a couple of days, we can see the impact that has on the behavior. And then sometimes that affords us the opportunity to discharge them from the ED. So that's the one silver lining. I would much rather have them get to a psychiatric facility quicker, but the ability to adjust in RED is nice.
I think psychotropic drugs just have such a huge challenge to them because it sometimes takes a little bit of time to see any sort of changes that occur, and stopping some of these drugs quickly can sometimes lead to some adverse side effects as well. And so when we are asked to make changes from the emergency department, it's really hard for us to do something like that without having some specialized expertise behind it, like a pediatric psychiatrist. We really depend on them and count on them to help us make these decisions, because it's not something that a lot of us are comfortable changing on the spot, depending especially on the child's history and what other medications they've tried in the past and how that's gone. A lot of these drugs have some side effect profiles that can cause more harm to the patient, so we really want to be cognizant of that.
The one situation we occasionally see is a kid that's been depressed for a while gets started on an antidepressant. Usually it's a sort of a serotonin acting agent, and then the kid is suddenly not depressed enough anymore not to be suicidal, and we see that happen in adolescence often, where the kid's on week 3 of let's just pick Prozac, and then suddenly they're now suicidal. And so again, that gets back to what we need to, what we like to know. Was there some drug that was started recently in that kid that perhaps is precipitating the crisis that we're seeing in front of us.
And I know here in Williamson County, and I'm sure in the surrounding counties, we do everything that we can to avoid taking children to an emergency department if we feel that there's another and better option, providing intensive outpatient care or follow-up services or emergency medication, and then direct to a psychiatric hospital when possible, or if there's something else going on that we feel that we think needs medical attention, we're sending them your way. However, we are finding in the field that there are no beds available in the system, that the entire system statewide is really struggling with capacity issues. And so, unfortunately, I think we're bringing more children and adolescents and young adults your way who a year ago we might have been able to find placement for them.
We, from the ED side, understand that essentially you've ran out of options by the time they get to us. We're dealing and live through that bed crunch that you're talking about in the community as well. So we know that there wasn't another option out there that you passed up on and came directly to the ED, because we're holding kids now for multiple days trying to find placement as well. And I was sharing earlier, we recently had a case that ran into hundreds of hours in the emergency department being held. So we see it and we're living through it, and so we bring them, come to us if you need us. That's what we're there for.
We are the safety net of the system, and we understand that when you are struggling to find a place for them, we know we're the option for them, and we're happy to help you all out.
We use the term first break or their first bout of psychosis, and maybe we should back up a bit and just talk about what that might mean to a field medic, why we might see that symptom in a patient.
So with psychosis, unlike depression, it can have pretty much a sudden onset. And in the two university towns that I trained in, one was Durham that has Duke University, and one was UNC that has Chapel Hill. What you would see is maybe a freshman who's now in a new environment under a lot of stress, has had some odd behaviors in the past, but that additional stress essentially causes them to have their first psychotic episode. And that is, I've seen everything from delusions of persecution, paranoia, hallucinations. So we'll say that the first break or the first psychotic break, and it refers to that very acute and rapid exacerbation of these psychotic symptoms. That can be extremely stressful for the family. And so I think you go the extra mile in terms of that medical clearance for that person and making sure it's not precipitated by recreational drug use, a bunch of stimulants that they're using to stay up for, they're having for the first time to not be on top of their schoolwork. And all of these things you just need to take into consideration. The family's going to be extremely stressed and potentially not even close to that patient. And so those are sort of some of the things I think around when I talk about that first episode of psychosis or that first psychotic break.
Perhaps we could get a little bit more in detail from you about the protocols you use once pediatric psych patients come into the emergency department. What medications you find most helpful in terms of sedation and restraint? Sure.
We have a protocol that starts off at sort of the lowest end, once again, when we talk about the drugs. We try to avoid those, though, with the behavioral interventions, de-escalation. But if it reaches the point that that's not working, we tend to go with either PO or IM Benadryl or diphenhydramine. And if that's still not working, we will escalate to Zyprexa. And then if somebody, again, is on that spectrum where they're, a big adolescent who's extremely manic, suicidal, or under the influence of something, then we'll go with ketamine. In terms of physical restraints, we have to have a doctor sign an order for that. And then once that order is reached, there's a finite amount of time they can be kept until they have to have a physician reevaluation. Peds, it's every 4 hours. It can be less than that, but if they're needing restraints, they have to be assessed. And then there has to be a sitter at the bedside that's doing an assessment about every 15 minutes to making sure that those restraints aren't in some way hurting the patient.
So I use a similar approach as well. I think just like Dr. Higginbotham said, start with the Benadryl, or the diphenhydramine, sort of antihistamine classes. And then I actually go up to benzos next, things like Ativan or Versed, and then go to the antipsychotics, either Haldol or Zyprexa are the options that I use. And then once we kind of surpass that, it's talking about ketamine. And then if it's beyond that, things like Precedex, like we touched on before. There are many different options for route of administration for a lot of these medications. Things like Versed can be given intranasally. A lot of these medications can be given IM, IV, or PO. This is just kind of hospital-based protocols, of course. And really remembering that as you escalate, the degree of monitoring that you need for these patients also needs to change. I think that is something that we often forget, and that's what can lead us into trouble. So, you know, at first, especially with things like IM and PO medications, we also have to be patient. Right? It takes a little bit of time for those to fully get in, and sometimes we are a little impatient and we're like, okay, give them another dose of this, or let's keep going, let's keep building, and then we really snow them.
Yes.
And then we forget that we have to also monitor them, and that's when we get into trouble. So I think remembering that patience, especially if you're using a route of administration that is going to be a little bit slower in onset, and then remembering to escalate the degree of monitoring that you're doing for these patients if you're doing that. I think those are two key points.
One thing that Sham said that I failed to mention, I think is key, is those sort of behavioral interventions before any kind of drug is used, to ask the family what helps. And particularly in some of these autism spectrum disorder kids or intellectual disability disorder kids, there may be just some behavior, some blanket bear, something that they have that acts as a way for them to self-soothe, and then you want to do that before you start up the ladder of drugs.
And so that would be something great for medics to remember, is to get that information on scene, if at all possible. Bring that transitional object or comfort object, if at all possible.
Yeah.
You know, I'm so glad you mentioned that. You know, and we really struggle in the field when we have a patient, you know, like you described, that might have some intellectual challenges or an autism diagnosis, and people are saying, well, it's just behavioral, and so we can't place them in acute psychiatric hospital, and so then we're all standing around on scene for an hour or two trying to figure out the most appropriate and, you know, kind and ethical way to help this patient. I think it's hard for all of us pre-hospital and once they're in your house, how to take care of patients that are in such distress, and there's not a lot of treatment options available, with residential treatment not available to many children in Texas, especially if they have some, you know, certain flavors of Medicaid or something like that that won't pay for residential treatment. We all spend a lot of time sort of circling around emergency care. It's a shame that it gets to an emergent situation.
Speaking of like a security blanket or something like that, I did have a patient the other day that was a little agitated, we were all a little bit on a high alert sort of situation, and immediately an aunt comes in and is like, oh, play some country music, and literally it just changed the entire situation.
Fantastic.
And it's just knowing these small things, and these are patients, right? And we got to remember that. And I think sometimes getting that small human element, especially in children, even though they're aggressive and they can be very dangerous at times, sometimes you just have to find that right button or know that small little historical fact, and man, it just changes the whole situation.
In your experience, how is it different to work with the parents of a child who's in a psychiatric crisis?
This is a very unique situation. I think the first step is really setting expectations. And understanding that this might be something that requires a little bit more patience and a little bit of a long-term solution in order to get to where their expectation is going to be. And then really reinforcing to them that our number one priority is the health and safety of their child. And I think that kind of puts them a little bit at ease. Making sure that we're stressing that, and it's not like a fracture where, you know, we can reduce it and they're in a splint and that's the healing process. You know, we're set. This is one of those things that we may have to try a few medications. We may have to titrate up on these medications. We may have to change some medications before we find the right fit for their child to help them improve.
So you would almost introduce it more of as this is perhaps the onset of a chronic illness, and so be patient with the process.
Correct. And there are a lot of parents that come in with the expectation that they may go home, or they come in with the expectation that they want their child admitted to a psychiatric facility. And it really depends on the extent of their crisis and how severe their symptoms are for us to help make that decision.
The situations I see that are kind of unique is that first psychotic episode. And so that can be quite a shock to a family. I find in those situations you need to address that medical clearance part, and about we are going to do everything we can to make sure this isn't something organic or a medical problem that's causing this. Those are some of the most difficult conversations that I've had with people. And then I think the other thing that's more important, particularly with some of that was the acute side. On the chronic side is just the level of frustration that the parents are having. And that you're seeing one moment in time when they've probably been dealing with this off and on for a couple of years, and they're carrying that into that interaction with you. And so I try to be understanding around that as well.
And I think, speaking to Eric's point, is we're just seeing them at this moment in time, and they've been dealing with this chronic illness for quite some time, and really understanding what has happened in the past and how best we can help that parent feel safe as well, I think is a very important point to take away.
Yeah, I think the most points I get is when I offer somebody a cup of coffee or a blanket. Just let them know that I know you've been here for 6 hours while we're trying to organize telepsychiatry or
Wait for labs to come back.
Yeah, wait for labs to come back. So here's some creature comfort to try to make this a little bit better for you.
What is the toughest thing that you guys have to deal with these patients in the emergency department?
Man, that's a tough question. I think the whole situation is really challenging, because it can be a very life-changing situation for the parents and for the patient, depending on what is going on. If this is a suicide attempt where there is true injury to some sort of the body organ, or to the point where they have to have ICU-level medical care first before we can get them the mental help that they need, that is rough on those caregivers, and really going the extra mile to tell them that we're there for their patient and supporting them, because in that situation, a parent may think that they have failed their children in some way. And I think experiencing that as a healthcare provider is really a challenge, and how we can help support them through this.
The situation to me that's most challenging is that person that's acutely suicidal and perhaps even had a suicidal gesture, but instead of it being something life-threatening, it was, a bunch of melatonin gummies. And you see that. I look at those and just look at the gesture, the impulsivity, and the underlying depression, and then have to have a talk with that family about the need for inpatient stabilization. And then it's really difficult when that family doesn't want that patient to be stabilized, and they think that they can manage it by taking the knives out or taking the medications away. And so those are the hardest conversations, where I, have to, sit down and really say, we don't do this lightly. This is really in the best interest of your kid. And then it's very, very rare, but there's instances where families are insistent upon leaving, and in those cases we have to involve Child Protective Services. And so again, that happens. There's months between those episodes happening, but it happens, and then we have to escalate it. And again, back to Sham's point, in the interest of putting the patient safety first.
And I think, for us, similarly, is the discussion around firearms.
I was just going to
out in
bring
the
that
field,
up.
that those are some of the most difficult conversations, especially if something traumatic has happened. But even if that hasn't been the case, maybe it's the melatonin gummies, but we know that there are firearms in the home, and how are we going to talk about that, and what does that mean, and what does that mean in Texas right now, and those can be very difficult discussions.
Yeah, having that firearm discussion with families is a very challenging discussion to have sometimes. To talk to them about, are there firearms at home and how are they stored? Even just bringing some awareness to that situation makes a huge step forward, but ideally kind of recommending to them that they should really be locked and stored away in a safe place, especially if their child is having symptoms that are mental health related, that are bringing them to the emergency room. And similar things with medications too.
Right.
Their own medications included, making sure that they aren't taking too many or have an opportunity if something abruptly changes for them to go overdose on these psychotropic medications, which are potentially deadly and dangerous.
Is there anything else that you guys would like to share with our first responder partners out in the field?
I think most importantly, gratitude. We are all part of one big team, and we really appreciate everything that you guys do out in the field and all the information that you bring us. You guys are real true partners in the care of this child, and we really appreciate all that you guys do.
Yeah, I'll echo that. I mean, we're, again, one big team, and all of us are living through this mental health / pandemic / financial crisis that's going on. So we're all in it together.
Well, thank you for being here and for talking about such a difficult but interesting topic, and thank you for partnering so well with us. We really appreciate it.